for joining today's webinar. So we are so honored as ACNS to collaborate with the EANS, especially the skull-based committee. So maybe I think we can have more knowledge from EANS doctors. So I think Dr. Roy is the chairman of the skull-based committee meeting. So maybe still he is not with us now. So maybe we can start. So maybe I think we want to have the current president EANS, Dr. Torstein. Can you say something, please? It's a welcome message.
Thank you. Desperately loading my slides. Thank you, Kato, and thank you for this initiative on behalf of the EANS. I'm very pleased that we can strengthen our ties to your society and share our knowledge, experience on skull-based anatomy. We have a very strong team from representing the EANS with Pablo and Luigi, and of course Roy will join us, I hope. And previously mentioned, Sebastian gives his apologies for not being able. He has a flight. We're together at the airport. If it's okay, I don't have the share screen button.
Yes, please. So the first speaker, that will be Professor Torstein. Are you ready?
I don't have on my screen the share screen button.
It should be there, Prof.
Here it is. Now it can, yeah. So is it this one?
How about now?
Yes.
I enable it for everyone.
Where is it? It's not.
The green one. Yes.
Okay.
Fine.
Yeah. Green. Good. Okay, good. So we'll talk about neurosurgical strategies for blister aneurysms, I think. Or was it clip wrapping? No, okay, we'll do this. Blood-rich aneurysms are rare. They are, of course, by definition at non-branching sites of also typically ICA, but they can also be in other vessels, and they account for about 7% of ruptured ICA. In or dissection aneurysms, they have a very fragile layer of adventitia, basically. So it's just a crust like any sore on the skin, rather than most often carotid, as I said, but do occur in other locations. These are some typical angiographic images, anterolateral or anteromedial wall, of the supraclinoid ICA. These are different examples. They are tiny, they are fragile, more common in females on right side, probably because of flow characteristics. And patients tend to be slightly younger than your average berry aneurysms. Treatment is urgent because they're prone to re-rupture, but often there is so much blood because of ICA rupture that they're difficult, and many patients need subsequent angiographies to detect them. Of intraoperative rupture, we know this even from the best of hands, I think from Barrow. They have also 40 to 70% intraoperative rupture risk. So it's a question of what to do. What we know you should not do is to sacrifice the ICA in the acute stage. Here we have a patient with subarachnoid hemorrhage. ICA was closed off because of, let's say, failed clipping, massive stroke, patient died. And this is typical for many of these, about 50% actually mortality if you close off ICA in the acute state. So we should really make an effort to preserve the ICA. the PubMed search with the search terms that you saw. So there is perhaps an increasing, or was at least increasing, interest in these aneurysms. In terms of treatment, microsurgical, endovascular, or combined. And every time we see a long list like this, we know that there is no simple solution to this. Endovascular options, ICA occlusion, coiling plus or minus stent assistant, multiple overlapping stents, and flow diverters. But here you can see endovascular therapy, quite a few procedural complications, perioperative strokes, etc. So endovascularly is not brilliant for these. Surgical options, direct clipping with or without protective bypass, and we have some Japanese colleagues who've done an excellent job on protective STA or even radial artery protection during attempted clipping. ICA ligation, again, with or without bypass, the Sund clips, or the clip wrapping technique that I will briefly discuss. So we had in our series, if patients had ICA sacrifice, the outcome was very, very poor. Most of them died, and one had poor outcome, Glasgow outcome score. If served, outcome was as any subarachnoid hemorrhage, good for some, and whether the ECIC bypass can push that ICA sacrifice group into this, let's say, standard group. Direct clipping can do it, and clip wrapping. Clip wrapping is external reinforcement of the wall secured by external clip. I personally use a Gore-Tex from pediatric thoracic surgeon, so it's, I think, 0.4 millimeters, so it's very thin, but of course it's not elastic. So this gives solid reinforcement. And after we started with this, we not had any intraoperative rupture. Stroke rate is 17%. It's high because of tiny branches or vasospasm. So this is not only surgery related, but disease related, the post-op stroke rate. That's important to emphasize. Many of these patients, of course, will have vasospasm and have some radiological strokes. So these are not clinical strokes, but radiological strokes. Good recovery in all. The bypass, again, as I mentioned, Kawashima and Japanese colleagues doing this, and doing ICA trapping with bypass. Again, if we looked at published literature, where it did a review and identified 13 articles, as can be seen here, total of 100 patients. So these are rare diseases. Median clinical representation was as any PCOM aneurysm, quite poorly. Of course, intentional bypass was pre-hoc, so planned in the majority of cases, and information not available in the majority of the rest. We can divide into protective or replacement. Of course, the protective after BBA clipping or replacement. The type of bypass was mostly ECA to MCA and not STA, because we fear that will not give enough blood. It did not occur with this technique in the majority of cases, and the bypass was patent in also the majority. Again, 12% infarct to 20%, so slightly higher than with the clip wrap technique that I use, and also a slightly higher mortality. Here are the modified ranking outcome scores in larger groups, so good outcome in 56% of patients. So with respect to bypass, there are few and small series. The data reporting quality is quite low. The main technique is higher flow bypass. Intraoperative rupture was reported between 0 and 75% with a mean of 12. So 1 in 8 post-op stroke, 1 in 5, and good recovery in 6 out of 10 patients. compared to clip wrapping and bypass, procedural complexity with clip wrapping is, of course, much lower. Intraoperative rupture rate, these are just my personal data. And you can see, at least in my hands, who do not have a huge bypass practice as some of our Japanese colleagues. I think my conclusion is that I will do clip wrapping rather than high flow bypass in these cases. But the optimal treatment therapy modality is unknown. And surgery offers superior obliteration rates than endovascular. I advise against attempted direct clipping with detective bypass. And the bypass ECIC is a viable alternative, but as I mentioned, clip wrapping is currently our first-line surgical modality. Thank you.
Thank you so much, Torstein. It was excellent talk. So just I want to confirm in acute stage, if you with wrapping material, so sometimes do you some experience the main trunk can be stenotic? Torstein, can you hear?
I do hear you.
Yes.
Did you
hear
yes.
my question? Yes.
Yeah, I did. Yes. So, yes, and in fact, I try to make it slightly stenotic. So typically what I do now is to use a Charbel probe, measure the flow before I clip wrap, and then I try to slight strangulation just because I want a bit of pressure against the let's say the wall defect, and then I repeat the flow measurement. Sometimes the clip is strangulating too much, so then you let up, and other times I tighten it slightly. Yes, but I try angiographically. I didn't have images here, but angiographically, I want to see a slight stenosis, to be honest.
Okay, thanks. So because we are wondering about vasospasm afterwards, so that's why hopefully we can keep the vessel length. Yes.
Do you see a lot of vasospasm of the ICA?
Sometimes.
No, yes. It's a worry, of course, but yeah. I mentioned, acute occlusion basically kills patients. In half the patients, they will go into stroke immediately. MCA infarct unless you do the bypass. In the other half, we see a delayed stroke due to spasms, but that is mainly spasm killing of ACOM. ACOM is the most important, not the PCOM, at least it seems to me. ACOM is where the battle is. Yeah. And perhaps one idea is to use the pellets that you have. They're not available in Europe. The nimodipine pellets that you have in Japan, and this would be very interesting to just put around the ACOM when we do surgery. Actually,
yeah. Fantastic. Thanks so much. So, Dr. Ben.
Yes. Again, very informative lectures, and thank you so much for sharing your experience in this. I think operative open approach to this aneurysm is difficult, and your experience is really important for us. I have two questions. The first one is about when you try to perform the wrapping. Do you need to drill the anterior canal to gain enough space for you to apply the clip? And because I think that sometimes you don't have enough space for you to for the clip, the foot of the clip to sit in the ideal position without drilling off the anterior canal. My second question is about your experience on the bypass. I saw in your series that there are two options. One is the high flow bypass, and another one is the SDMCAs. How do you choose between them? And what do you think in your series? You mentioned there are some post-op stroke, and so what do you think is the contributing factors?
Yeah, so first, the anterior clinoid, it's a very good remark. And yes, I often do it to have enough space, even for PCOM aneurysms, to be honest, if they have a certain size. For these, tip to intradural, so not a complete resection of this, the zones A, B, and C of the clinoid. But yes, this is often the case that you need to see well, because PCOM can often be sacrificed because the perforators will be filled from posteriorly, but of course the anterior choroidal you cannot touch. In terms of the stroke rate, yes, it's high, but as I said, this is angiographic, or sorry, radiographic. So these are imaging-based strokes. So not all of them are symptomatic. Technique. Majority I ascribe to vasospasm. High flow will not, cure
Yes.
cure vasospasm. So yeah.
Thank you. So
Yes.
Professor Kato, please unmute yourself.
So, no more question? Thank you very much, Torstein. Maybe I think in the future, I think very, we need a less invasive treatment for those kind of the very special aneurysm. I think maybe the endovascular, I think the stent can be hopefully, I think one of the best solutions.
I have another talk on the surgery versus endovascular, and yes, I agree. If covered stents, so multiple stents, seems to have a lower, at least in published literature. I did a systematic review, some 4 years ago or so. They seem to have a lower complication rate than flow diverters.
Okay, yeah.
I understand why, it could be coincidence. So I'm not sure, but I'm a bit reluctant based on the data to offer flow diverter. But, two stents overlapping is certainly an option. Attempted coil has attempted clipping a very high rate of intraoperative rupture in the reported literature.
Right. Yes, right. So that
There is one raised hand in the audience.
yes, please. Dr. Ben, can you go on?
Dr. Shara.
Dr. Biswas?
Yeah,
Biswas from Bangladesh, I think. Young doctor.
Two questions, if you permit. Number one is, how do we angiographically evaluate this patient? Definitely, I'm talking about the DSA. It's to take decision whether endovascular or microsurgery. And second question is, what is the experience with endovascular treatment? Assisted coiling, we trained assisted coiling in Blister aneurysm, especially the paracranial segment.
Austin, can you hear?
I heard him speak, but I did not hear the question.
So maybe I think his question is how you can evaluate with image angiogram. So how you can decide, how you can choose the treatment way, endovascular or open surgery, based on the angio, or maybe 3D CTA. Yes.
Yeah, I'm not really basing my decision on the radiographic findings as such, with the exception that sometimes you have a very broad of these. Most of them are just tiny blebs, but if you have this more, I shouldn't say Mount Fuji, but more elongated, and it ends all the way distally to the anterior choroidal, then I know I cannot safely clip wrap. I will run the risk of strangulating the ACOM. The PCOM I'm not so worried about, as I said, but the anterior choroidal is critical. And then I would be much more inclined to put, ask for, I don't do it myself, but ask for two stents, a covered stent.
Okay. So Biswas is okay? So it's a kind of the...
Yes, I wanted to know any experience or any possibility of doing.
We are sorry, I cannot catch your voice clearly. Okay, so just you can write to me. I will ask Torstein later. Okay. So, Professor Torstein, thank you so much for your nice presentation. It's quite a difficult issue, I think. Thank you so much. So the second speaker, I want to invite Professor Kohno Sensei. I'm sorry, Pablo. Pablo, are you ready?
Yeah, I am ready.
Hi, please start your lecture, please.
Okay.
So,
It's always a challenge to speak after Torstein, but I'm quite used to it, unfortunately.
If anyone could do it, it's you.
So let me share my screen, and you let me know if you can see my slide properly.
yes.
Yes.
So thank you for this fantastic initiative. It's a big pleasure to be here and big honor. And my plan is to speak on something quite common, which is how we can take advantage of understanding the anatomy and squeezing the technology that we have in the OR for dealing with tumors in the posterior fossa. So first message is that the intracranial volume is quite big if we consider that infratentorially, which means posterior fossa, is less than 1/3 of all the intracranial volume. So it's a very small structure in which we have very important bones, foramina, fissures, layers, stent, venous sinuses, vessels, arachnoid membranes, cisterns, important neural tissue, and more importantly, vessels and cranial nerves. So we could say that it's a very narrow area in which we have to deal mainly with benign lesions. So there are many different routes, well-known, far lateral retrosig or lateral suboccipital. Then we have the midline suboccipital, which could be purely midline or paramedial, depending on the approach we want to perform. And then we have the complex transpetrosal approaches. All these are the routes, common routes, which could help us to implement and squeeze the surgical approaches in the posterior fossa. So talking about technology, nowadays we have all the robotic stuff, but I will concentrate on simple things that we have in the OR. And I want to share with you how we are implementing this stuff. And mainly we have perioperative imaging studies. We have fantastic new technologies like DTI tractography that we are using quite a lot. And then intraoperatively, we have neuromonitoring, visualization devices, important microsurgical tools. 90% of the time during surgery, we have just a suction device and our bipolar or micro scissors in our hands. So this is very important. The fantastic high-speed drills and the ultrasonic aspirators. So going to probably the most common approach for cerebropontine angle pathologies, which is the lateral suboccipital or retrosigmoid approach. This is how we really place patients in a kind of lateral position, and then we rotate the head towards us. We try to identify the asterion, which will give us the relative location of the transverse sinus. So this should be the sigmoid sinus right there. This is the mastoid, this is the digastric groove. And then we do a bar hole just above this asterion, and we drill quite a lot in order to expose the posterior part of the sigmoid sinus. So then when we are dealing with a tumor like this acoustic or vestibular schwannoma, one of the most important things is where is the cranial nerve located. What is the facial nerve? What is the trigeminal nerve? And trigeminal nerve generally is very easy to be found in the T2 volumetric analysis, but the facial nerve usually is a bit more complex. So we are squeezing the use of this DTI tractography. And with that, we can have a relative orientation before removing the tumor. So you can see how this correlates quite nicely with what we found intraoperatively. So sixth nerve and facial nerve with the trigeminal nerves. So we can have a good idea of where is the tumor located regarding to the facial nerve. how we can even see the fascial nerve without watching it directly. So we are implementing in the last 8 years this electrified ultrasonic aspirator. So we just connect the ultrasonic aspirator to the neuromonitoring device, and with this button we can have a direct control of that. So we start removing the tumor from posterior to anterior, and once we are getting close, we just touch that button and we check how far we are from the fascial nerve. And this is a good technique in those cases in which we decide not to do a complete resection of the tumor, but leaving a small layer of tumor on it. We did a research on that, and we had 35 patients in which we were checking directly with the mono and bipolar probes, and then exactly in the same points before the resection, we were touching those areas with the ultrasonic aspirator to check how accurate it is and to adjust the parameters. So once we found some response, we marked every single area, and then we did the stimulation with the monopolar probe and then with the ultrasonic electrified aspirator, checking the accuracy of themselves. Even if we see the trigeminal nerve, that's very good, because we can even stimulate through the tumor and check how far it is, and then directly measure that distance. So this was these were the results, and the concordance was quite high in all cases. So another thing we can do with the intraoperative neuromonitoring, and this is a research we are carrying out in the last 5 years, we are stimulating the different branches of the trigeminal nerve in an antidromic way. So we can even check which part of the trigeminal nerve we are facing during surgery. So this was a challenging case because this patient had this venous compression on V1. So the symptoms were mainly located on V1. Once we expose the trigeminal nerve, this is the motor rootlet, we have a quite massive suprameatal tubercle. So that's why we introduced the 30 degrees endoscope, and we saw this compression of this capricious superior petrosal vein. So then we drilled with high-speed drill the suprameatal tubercle in order to expose that area. And exactly this is what we are doing in all the cases. Where the compression is located, we are stimulating and checking which branch is that in an antidromic way. And we have a very strong concordance also with this technology. So surgical tools in the posterior fossa, as we said before, we have many carinary nerves and important neural tissue. So we are trying to electrify as many surgical tools as we can, even the small dissectors and all the probes. We have a box with electrified tools, even the high-speed drills. We can electrify them with a small forceps. So during a mastoidectomy for a cholesteatoma like this one, we can check the relative location of the fascial nerve, and we always check it, double check it with the gold standard, which is our monopolar probe. So we can electrify anything. Regarding the visualization devices, we have fluorescence, which is very useful in an hemangioblastoma like this one. So once we expose it, supracerebellar exposure, we can see the main branch which is feeding this hemangioblastoma, and also where is it draining to the tentorium venous sinuses in this case. So we do a circumferential resection. This was a very interesting case because this was a single hemangioblastoma, what we saw in the MRI. But once we finished the resection, we checked again with fluorescence, and we realized that there were 2 small spots. These were silent hemangioblastomas that we sent for pathology, and we published this finding in the Journal of Neurosurgery a few years back because it was a very interesting silent discovery of hemangioblastomas with intraoperative ICG, which were not seen in the pre-op imaging study. Regarding fluorescence, we can also use it in order to decide the point in which we want to do a tentorial opening. This is a cavernous hemangioma in the lateral aspect of the midbrain, but going quite high. So in this case, we wanted to cut the tent a little bit. So for that, in order to try to avoid big venous sinuses, what we use is a pulse of ICG. So here we have the tent, and we saw a quite big venous sinus right there, quite anterior. So we did our cut a bit more posterior in order to avoid this uncomfortable bleeding. So this is about the fluorescence on the microscope, but we can also take advantage of the different lengths of the endoscope. So this is a very small vestibular schwannoma in a kid, 14 years old kid who had this growing tumor in less than 6 months. So we decided to do a retrosigmoid and transmeatal resection. So you can see how the tumor is almost reaching the fundus, and we could only drill 9 millimeters due to the location of the labyrinth. So it was a bit challenging to reach the most anterior part of that. This was the cochlear nerve. This is the fascial nerve. And then we introduced the 45 degrees endoscope to realize that there was a small remnant in the most anterior part. And we were able to remove it with this endoscopic assisted technique. So endoscopes can help us a lot to deal in hidden corners in the posterior fossa. This is another example in which we are removing this dermoid tumor located in the CPA quite anterior. This is the fascial nerve, which was very difficult to see during the microscopic exposure. So we started in the superior window, removing the dermoid tumor, and then with the 45 degrees endoscope realized that there was a remnant in the most anterior part, just in front of the 𝙎𝙬𝙧𝙎𝙬𝙀 foramen, and hidden by the flocculus and the fascial and cochlear nerve. So this is again how the use of technology, intraoperative technology, can help us to have a better result. And we can do almost in certain number of cases a purely endoscopic surgery. This is the ventriculoscope indeed, the neuroendoscope with the working channel, and this is a quite big arachnoid cyst, which was causing uncomfortable hearing problems to this patient. So you can see how through the working channel we can do as many cuts as we wish to expose and completely destroy this arachnoid cyst. So we can expose all the posterior fossa from the lateral view. So this is the medulla oblongata, and this is all the way to the midbrain with all the cranial nerves in a very small craniotomy. And we can integrate all these tools in order to deal with tumors like this. It is a pilocytic astrocytoma, which was quite exophytic at the level of the protuberance in the left side. So we did a lateral suboccipital craniotomy, quite massive. And in this case, the beauty of the use of all these electrified tools gave us a nice orientation about the relative location of all the cranial nerves. So this is the most inferior part. I have to drill a little bit C1 lamina in order to expose the most caudal part. This is the vertebral artery entering, and now this is not exophytic enough. It's quite dissectable, this part, and we are moving up in between the fascial nerve and the lower cranial nerves, where the tumor is quite close to the protuberance. And at this point, it was very important to use the electrified CUSA in order to check the corticospinal tract. Even going superiorly, we need again to cut the 10th in order to expose the most superior part till the 3rd cranial nerve. So in this case, I just wanted to share with you how important it is to have all these electrified tools. It was really helpful in order to get a good removal. There was a small remnant on the contralateral side, and 3 years later, I had to deal with this part on that. So just to conclude, I think in neurosurgery, this is my message. This is what I'm learning. Anesthesia and hemostasis are very important. Anatomy is fundamental. Technology is something that we have to apply, and surgical skills indeed is probably the less important thing, because even any one of us can learn to do that. But we need to have a very strong basic knowledge. And remember that a fool with a tool is still a fool, but probably a more dangerous one. So it's very important to squeeze and optimize the use of all this technology and never stop learning from our best teachers who are our patients. Thank you so much.
Okay, Pablo, thank you so much for the wonderful talk. Thanks so much. So I think anatomy is the most fundamental and the very important things. So I think recently, do you use the pure endoscopic procedure or endoscope assist?
Mainly, I use endoscope assisted. It's very rare the case in which I do purely endoscopic surgery. This was a extreme case because it was a huge arachnoid cyst, and all the space was created for us to get in. But otherwise, I use assisted endoscopic, and it's very useful in many cases. You can see really hidden corners that you cannot perceive nicely with the microscope, and then you can go in with the microscope and do a good job.
So maybe you can encourage the EANS to join the cadaver section course. Yes?
Yeah. Fantastic.
Yes. Thanks so much. So there's a man?
Yes, Pablo, nice to listen to your lecture again, and very impressive lectures. I want to ask about your the electrical aspirator. Do you develop it by yourself, or is it from another company? I think it's quite useful, especially when you debug the, for example, the vestibular schwannoma. You can know how when you have to stop and do the dissection. I think it's quite a useful tool. Also, you mentioned you use the angle with the bipolar. So, in your experience, what is the difference? What is the advantage of using those bipolar compared to the our usual probe? And another question is about, I saw that you use the ultrasound to scan the eyeball in one of the photo. I would like to ask, are you doing the are you trying to insert the electrode to monitor the extraocular eye movement, to monitor the third and the sixth nerve, and also the fourth nerve? Can you share your experience with us?
Yeah. So regarding the first question, yes, this is regarding the ultrasonic aspirator. Indeed, the first one we were using, it's one which the liver surgeons use as monopolar coagulation. So the device is held by a company. I think it's Integra, I'm not sure. And it is used to coagulate, but with an adapter which was designed by our neurophysiologist. You can connect that device to their neuron monitoring device. So yes, it's distributed by a company. Regarding the second question, I do prefer monopolar because it's more, let's say, easy to perform. But our neurophysiologists, in case we can, they always prefer, obviously, the bipolar, because let's say it's a bit more accurate when we are directly stimulating into the nerve. And I found it very useful, especially when the facial nerve is not seen directly. So I can go behind the schwannoma and check how far I'm from it. And the third question was regarding the use of the ultrasound. I use that picture because our anesthesiologists, they like to use it to check where is the nerve in the periphery. And I don't think it's something quite, let's say, necessary, because you can always check where the foramina are located, but they prefer to use it because they are using that for occipital nerves and any other nerve. So it's a kind of training for them, but I don't think it's necessary for B1, B2, B3.
I see.
Thank you.
So thank you very much, Ben. Maybe we can take two more comments from Dr. Kohno. So, Sensei,
Yes.
can you give some comment, please,
Yeah.
for Pablo?
Hi, I'm Professor Kohno from Tokyo. So I enjoyed your talk, nice talk, and skill is very good, I think. But you mentioned about the electrified ultrasonic aspirator or drill. It's an idea from the Professor Silverstein, maybe 20 years ago. He wrote many papers regarding such good idea. But I recommend to use continuous facial nerve monitoring. So continuous high frequent stimulation with the root exit zone of facial nerve, that's much better for us to preserve the facial nerve function, I think. So so try it. Yeah, my recommendation. Yes.
Pablo?
Thank you.
Yeah,
okay?
Yes. No doubt about it. I appreciate that comment. I just wanted to share with you. Of course, this was not our idea. Indeed, it's has been quite largely published many years back. I remember a nice paper from Suomi Constantini in which they were dealing with this electrified 𝙬𝙬. Maybe it's 15, 20 years back, also publication, very nice one, for intrinsic thalamic and peduncular gliomas. And what we did with this research is just checking every single point in which we were using this continuous ultrasonic aspirator stimulation with a monopolar probe to check the distances in between the remnant of the tumor and the location of the fascia nerve. That was the point of our research. And of course, I do agree with you about high frequency direct continuous stimulation. This is the gold standard, and this is a really fantastic test. Thank you so much.
Thanks so much. So maybe one more just from Dr. Torstein. Can you make some comment for Pablo?
Outside what has been shown, I'm aware of course of the equipment. I agree. Congratulate on the surgical technique and the results. It's very nice. I know him as excellent teacher, but he's also a very, very good surgeon who can use incorporate these different techniques. There are many techniques out, and it's quite difficult to navigate and fairly complex to incorporate. So I just have congratulations, really. When I have to apologize. I need to go because my flight is boarding in 10 minutes.
Okay.
So I apologize for the conflict here.
Okay.
But Pablo and Roy will hopefully, and Luigi will carry the EANS mantle.
So thank you very much. So Torstein, maybe please continue the collaboration with the ACNS. Thank you so much. So have a good flight. Bye. So then the next speaker is, I think, I don't see the Abhidha Shah, maybe the Professor Michihiro Kohno sensei. Are you ready to talk? Yes.
Yes. So I'll share my slide.
河野先生、自分の学会のアナウンスもしてもいいと思います。
ちょっと今日は入れてないですね。
入れてない。
そうだ、入れるべきだったな。OK、ちょっと待って。これかな。じゃあ最後に。
それ入れましょう。
最後に。はい、OK。
はい。
Can you see?
大丈夫です。
Okay. Hello, everyone. I'm Professor Kohno from Tokyo, Japan. I talk about the surgery for jugular foramen schwannoma today. About the COI, there is nothing to disclose. Before starting my presentation, I'd like to introduce myself and our institute shortly. I'm a chairman of the Department of Neurosurgery at Tokyo Medical University, Tokyo, Japan. I'm a scholar-based surgeon and once active member and president of Japanese Society for Skull-Based Surgery and Japanese Society of Acoustic Neuroma. At the Skull-Based Center of Tokyo Medical University Hospital, we perform surgery for CP tumors 2 or 4 cases per week, totaling about 150 cases per year. My personal experience of surgery for CP tumor is more than 2,500, including 1,800 vestibular schwannomas. I operated nearly 200 jugular foramen tumors, and schwannomas accounts for nearly half of our series, and meningiomas and glomus jugular tumor and others like these. We have to know about the complex surgical anatomy around the jugular foramen before to do the jugular foramen tumor surgery. This is the right side from outside after mastoidectomy, and the right side from inside via the retrosigmoid approach. Jugular foramen schwannomas. So according to the type classification from the Professor Fukushima's group, for type A intradural tumor, we use the retrosigmoid approach. And for type B, dumbbell-shaped, or type C, triple dumbbell-shaped tumor, we use the transmastoid transjugular approach. For type C, we add high cervical exposure. About the roots for jugular foramen tumors, retrosigmoid approach has two additional options of retrosigmoid suprajugular and infrasigmoid approaches. And transmastoid transjugular approach has two ways of transmastoid suprajugular and transsigmoid approaches. Using this illustration of the light triple dumbbell-shaped tumor, retrosigmoid approach and two additional options of retrosigmoid suprajugular and infrasigmoid approaches, and transmastoid suprajugular and transsigmoid approaches like this. About the type A intradural tumor, we sometimes encounter these tumors extending into the upper jugular foramen partly. For these tumors, we drill around here to open the gross pharyngeal meatus to take the tumor extensively under the continuous vagus nerve monitoring, like this. We wrote about the suprajugular approach in several times, like this. In this case of the intradural type, extending into the upper jugular foramen, we use the retrosigmoid suprajugular approach. Right side, we can see the 10th and 11th nerve, and this must be the gross pharyngeal schwannoma, and we can see the 7th and 8th cranial nerves. After taking the cisternal part of the tumor, I'm drilling around the upper jugular foramen to open the glossopharyngeal meatus here. So tumor was totally removed, preserving the healthy fibers of the 9th nerve and the 10th and the 11th nerve. We can see the drilled area here. Dumbbell-shaped tumor. This is the case of the dumbbell-shaped tumor, and we use the transmastoid suprajugular approach, preserving the sigmoid sinus. Right side, mastoidectomy first, and I'm dissecting the sigmoid sinus, and I'm drilling around the jugular valve. This is the foraminal part of the tumor, and this is the jugular valve. Cutting the presigmoid dura, and we can see the cisternal part of the tumor, this one. And also we found the 10th and 11th nerve here. So this must be the gross pharyngeal meatus. And I started the continuous vagus nerve monitoring. Internal decompression first. 7th and 8th cranial nerves. And after that, I am approaching to the foraminal part of the tumor. Jugular valve here. The tumor was totally removed. 7th and 8th cranials. Post-operative course was uneventful. About the infrasigmoid approach, we drew jugular process extensively, and after cutting the condylar emissary vein and the marginal sinus, elevation of the sigmoid sinus allows us to enter into the jugular foramen from medially. Left side, dumbbell-shaped tumor. Partial mastoidectomy first. We can see the condylar emissary vein and jugular valve and internal jugular vein, or something wrong. Via the sigmoid sinus, via the retrosigmoid approach, tenth nerve here. Too bad. So I'm doing elevation of the sigmoid sinus like this, and we can see the foraminal part of the tumor. Very, very bad. So, preoperative hearing disturbance improved the normal condition. Tumors totally removed. Triple dumbbell-shaped tumor. Many big names use the transsigmoid approach for these tumors. In this case of the triple dumbbell-shaped tumor with a large extracranial part with occlusion of the sigmoid sinus, we selected the transmaster transsigmoid approach. Left side, after high cervical exposure, I'm doing mastoidectomy very quickly. This is a large extracranial part. We can see the internal jugular vein, ligated and cut, and deflected toward rostry. So after ligation of the sigmoid sinus, transsigmoid approach here. 10th nerve here. I am approaching the large extracranial part of the tumor. So in this case, lower cranial function was totally compensated by the other side. So I took the tumor totally. Sorry. About the continuous vagus nerve monitoring, if we preserve more than 30% of the M marks compared to the control before tumor dissection, we don't have to worry about the worsening of the lower cranial functions. In our series, preoperatively, hearing disturbance observed 40% of our patients, and facial palsy, facial nerve palsy, dysphagia, hoarseness, SCM trapezius atrophy, and hypoglossal palsy. Postoperatively, 1 year after surgery, hearing disturbance often improves, but SCM trapezius atrophy is apparently worsened in 20% of our patients. But generally, I think it's good results. In summary, in jugular foramen Schwannomas surgery, sorry. Selecting an appropriate surgical approach is very important to obtain excellent surgical results. using an intraoperative continuous vagus nerve monitoring is useful to increase the tumor excision rate while avoiding severe postoperative vagus nerve palsy. And hearing disturbance often improves after surgery, and the postoperative overall function results were generally good, maybe due to the compensation of the lower cranial functions. Thank you for attention, and if you have some interest, please visit us. And lastly, I'll do the ad. So I'll have the combined meeting in Tokyo. July 3 to 6, 4 days at the center of Tokyo. Japanese Society for Skull-Based Surgery, Facial Nerve Research, and conference on neurosurgical techniques and tools, and aesthetic neurosurgery. Please visit us. Thank you.
Thank you so much, Michihiro Kohno sensei. Wonderful talk. So I think you talked about the relation with the anatomy and surgical approaches and results. So I think maybe Pablo, any comment for him?
Thank you. Thank you, Professor Kohno. That was a really motivational talk and really fantastic. I've always had fear to deal with such massive tumors, which are intra and extracranially, mainly those paragangliomas or jugular foramen, big tumors, because it's very difficult to me to predict where I will find in the extracranial part the lower cranial nerves. So I don't know if you have any view about how to predict where you will find those cranial nerves to try to preserve them, at least from an anatomical point of view.
Yes, so I mentioned, so monitoring, so result, it's so same as the neurosurgical results, same. So if we preserve more than 30% compared to the control before surgery, so we don't have to worry about the worsening of the lower cranial function. So, and if the case, the compensation from the other side is completed, we don't have to worry about any worsening of the neurosurgical deficits. So we can do the total removal or something in a younger patients. Monitoring is everything, I think.
Thank you.
Pablo, is it okay?
Yeah, thank you so much.
Okay, thank you, Kohno sensei. This shot from Uzbekistan.
Thank you so much, Professor Kohno. Hello, everybody. It's a pleasure to be in this wonderful webinar. Professor Kohno, I have a question. When you use the continuous monitoring of the vagus nerve, is this the same technique can be used for example, vestibular schwannoma in the preservation of the facial nerve?
Yes, that's true.
Yeah. So you recommend to do a continuous monitoring for the facial nerve as well?
Same theory, and so difference is just the 7th nerve or 10th nerve. So it's very easy to guess the nerve's condition, functional condition. We can guess. That's why I recommend to Pablo.
Thank you.
Yeah.
So you said the monitoring is everything you said. Okay, thank you very much. So no other question? Kohno sensei, all the best for your upcoming, combining the Congress in Tokyo.
Okay. Thank you. Yeah.
Hopefully everybody wants to join his Congress, please. Thank you very much. Thank you. So next one now is maybe Dr. Roy. You join now. So as chair of the skull base committee of the EANS, you want to say something or a welcome message? And please do your lecture.
Hello, can you see my screen?
Yes.
Can you?
Yes, yes.
Okay, thank you very much, Professor Yoko Kato and Professor Kohno. And I thank Professor Liu for giving me this opportunity. And hi, Pablo. And the topic I was supposed to talk to you today is how to limit the morbidity of petrosectomy. And we had the opportunity after following some dissections in our laboratory to look at this particular problem and devise some new strategies to deal with the classically known complications of petrosectomy. So just to give a short preview of the anatomy, it's an apical. The petrous bone is a pyramidal kind of bone with an apex, middle aspect, and a base, which is the mastoid process, which has the antrum and the air cells. The middle aspect has the most important parts, which are the cranial nerves and the internal artery meatus, the middle semicircular canals, and of course, the apex has important structures like the petrous carotid, the Meckel's cave, and the cochlea. The surgical approaches, as you can see here, the classical approaches of the anterior petrosal and the posterior petrosal, just to get the nomenclature right. The combined petrosal is when you combine these two, the anterior petrosal and the posterior petrosal. The anterior petrosal approach gives you an excellent exposition of the upper petroclival region and gives you a very good approach to the ventrolateral surface of the brainstem. And you know the pathologies that can be treated through this. These are the meningiomas, the chordomas, the schwannomas, and the brainstem cavernomas. The anterior petrosal approach is an approach through the middle fossa, and it's an extradural subtemporal approach, and it involves the drilling and the removal of the petrous apex. And the anatomy of that can be best appreciated from the medial surface of the petrous bone, where you can see on top the superior petrosal sinus, and then the inferior petrosal sinus forming an angle at the confluence there. And there at the back end of the petrous apex, you have the internal auditory meatus, and that's the area of the bone that we need to remove to reach that point. What are the key anatomical landmarks? The key anatomical landmarks is essentially for the young people in the audience of the ACNS and the EANS, is that the root of the zygoma is divided into 3 points, the anterior, middle, and the posterior, and they correspond in the depth with the ovale, the spinosum, and the geniculate ganglion. So that will give you a rough surface marking when you plan the trajectory for these structures. The floor, and this is a cadaver dissection that shows you the approach, and you can see that the dura has been reflected off the floor of the middle cranial fossa. And here, this picture also shows you the lateral wall of the cavernous sinus removed. So, but your petrous apex would be somewhere in this region. And that's just to give you an orientation of the same. And if you were to cut the trigeminal root and pull it back, you can see the whole carotid in the petrous. Of course, you won't be doing this in an apical petrosectomy, but just to get you the anatomy right. That triangle shows the area of the bone that needs to be removed. These are the structures that you would see in the approach. You have the 3 roots of the trigeminal nerve, the 7th nerve inside within the petrous bone, the carotid in the Glasgow triangle, and the middle meningeal artery that you see here. But to put it in the position of the surgery, this is what it would look like, and your petrous apex would be in this region here. That's the bone that needs to be removed. To get you the orientation right, and if you drill deeper, you can see the posterior part, which we do not want to address with the apical petrosectomy, but that's the semicircular canals. And the limit of the apical petrosectomy will be the contents of the internal auditory meatus. And what are the boundaries of the Kawase triangle as it started? It was described initially by Kawase as a triangle and later modified to make it a quadrangle, really. And these are the borders. On top, you have the petrous ridge with the superior petrosal sinus. And then you have the trigeminal roots and the GSPN that kind of hides the carotid there. And then posteriorly, you have the arcuate eminence and the internal auditory meatus. So the standard dural opening when you do this kind of petrous apex, apical petrosectomy, is you open the posterior fossa dura and you continue across the superior petrosal sinus onto the temporal dura, and that gives you an opening, and you cut the tentorium, and it gives you an opening onto the region that we are talking about. And the tentorium should be cut all the way to the incisura and to stay away from the fourth nerve. Now, this is the standard dural opening seen on the left side, anterior here. This is the V3 root. And if you move the V3 root, you can convert that triangle into a kind of quadrangle, a rhomboid, actually, and that will get you more anterior exposure. And that's the root entry zone of the fifth nerve that you see here. The combined petrosal involves a posterior petrosectomy as well, and in addition to the anterior petrous bone. And what are its advantages? The advantages, especially for meningiomas, if you do a combined petrosal, is that there is a massive devascularization of the tumor. It reduces the working distance to the target. It gives you multiple lines of sight and a very good control of the interface with the brainstem. But what are its disadvantages? It's time consuming. It's technically demanding. It needs good dural repair to avoid a leak. There is a risk to the cochlea. And the main problem that we would like to address, and this is the problem why many people have moved away from petrosectomy, is because of issues with temporal lobe retraction and injury of the vein of Labbé. So we looked at the literature behind that to evaluate if this is a morbid approach or not. And we looked at these papers by Spetzler's group, and they did find a significant difference between a standard retrosigmoid approach and a petrosal approach. And that opens up, and that also was proved by our study, which we looked at the systematic review and meta-analysis. So the complication rates, we have to look at petrosal approaches from a complication viewpoint. You have to try to differentiate between the tumor-related morbidity, which is common for any approach, and the approach-related morbidity. So when you look at only the approach-related morbidity, it is significant, and therefore newer approaches need to be looked at. And what are the temporal lobe issues that we could address? Now, we know that it happens in at least 6% of cases, and this is from the Froelischer's group, which is very well known for this approach. So they're, if you wish, the best in the business, and even they had a 6% venous issues with this approach. And it is related to the vulnerability of the vein of Labbé during these approaches and the temporal lobe retraction. So this is what we are trying to avoid. Our work in the laboratory allowed us to kind of develop this new approach to reduce at least the approach-related morbidity in this. And what we are trying to do is a tentorial peeling. It is possible to open up the tentorium to like a book that will kind of cover the areas at risk, the temporal lobe and the vein of Labbé, and this can allow us to protect these structures during these approaches. Now, if you look at this diagram carefully, these are coronal images, and that's the petrous bone there. This is the temporal lobe, the cerebellum, and that's your superior petrosal sinus. So if we were to do a petrosectomy, either anterior or a combined, and we keep it retro-labyrinthine, and if you reflect the dura of the middle fossa floor and you reach the superior petrosal sinus, and that point, if you were to cut into the dura there parallel to the superior petrosal sinus, then the tentorium can be split. And when it is split, it splits into two layers that we'd like to call the temporal tentorial leaf and the posterior fossa tentorial leaf. Now, the beauty of this is the fact that this entire dural reflection, which is the split tentorium, will cover the entire tentorial lobe during the whole surgery. And you don't need to visualize the temporal lobe at all when you're operating something in the region of the petroclival lesion. And the PFTL will need to be opened to expose the lesion. So you can keep the TTL closed during the entire duration of the surgery. So I don't know if I have the time, but I would like to show you a quick video. So this is a cadaveric video. You can see the same diagram that splits into two layers, and that's your retrolabyrinthine petrosectomy, and that's the middle fossa dura that you see here. And the dura can be opened, and we found that it is easier to open the dura near the V3. So that's where you're likely to be able to get these two layers. And then after that, we just need to split the two layers. And you have to imagine that the splitting of the two layers is exactly like peeling the lateral wall of the cavernous sinus. In fact, it is the same extension of the cavernous sinus that goes on to the tentorium. So once we reach that beautiful avascular plane between the two layers, it just opens out like a book, as you can see here. And that is the TTL, and that's the PFTL. And then the dura can be opened wherever the pathology is. Once you keep opening that, it just opens up all the way to the tentorial hiatus, and you can leave it there. And beyond that is the fourth nerve. So if you were to open in that, the dural opening, as you can see there, is like standard. And what you need to be opened, if you need a posterior fossa approach, then you need to open the posterior fossa. If you need a temporal lobe part to be exposed, you open the temporal tentorial leaf. And this is just the diagrams that show the opening of the dural incisions in the tentorium, the PFTL and the TTL, and it can be opened as required. What are the limits of the intertentorial approach? One of the things that you cannot do is the posterior transposition of the sigmoid sinus. And that will restrict your approach a little bit. And we are currently just an article that compared the two approaches between the standard petrosectomy and the intertentorial approach, shows that there is a restriction of approximately 15% of the angle and the vision. So that's all. You lose only about 15%, but while you lose that, you gain the advantage of keeping the temporal lobe completely covered. The other anatomical variations that need to be factored, you have to watch out for tentorial venous lakes, but they are easy to control, actually. And of course, you have to look at venous variations. That is, if the vein of Rosenthal or Labbé drains into the superior petrosal sinus, then you might not want to consider this approach. Just show you one clinical case.
Anterior petrosal intertentorial approach for the resection of.
Yeah, so that's. Yeah, so that's a patient who had this tumor, the large tumor of the petroclival region. It was a chordoma to start with. And I'll show you, this is the approach which I already described to you in detail. So that's how we position the patient. And this is, we are trying to, that's the middle meningeal artery. We're trying to reflect the middle fossa dura off the floor. You cut the middle meningeal artery. Now, this is nothing new for any standard anterior petrosal approach. These are standard techniques. So that's the V3 that you see there. And then you move the middle fossa floor. You can see the GSPN above there. And there you would dissect it off that so that the middle fossa, the dura of the middle fossa floor can be reflected. And then that's reflected. That's the GSPN that after that you keep reflecting it till you reach this Petrus ridge. And that's your Cavase triangle. That's the position of the internal auditory canal. So an extended Cavase's approach needs to be done. So the bone removal should be maximum to all the way up to the cochlea and the internal auditory meatus. Posteriorly, the V3 should be moved so that you can take out the entire apical petrous. That's your opening of the posterior fossa dura that allows some decompression. And once you reach the superior petrosal sinus, then we do that cut. This is the new thing. You cut the dura parallel to the superior petrosal sinus. That allows you to reach that plane between the two layers of the tentorium, and then you just keep opening it, just like you would do the lateral wall of cavernous sinus, and you keep, if there is any bleeding from any venous leaks, you just put some flow seal and some hemostats. And then, of course, here in this case, we need to cut the superior petrosal sinus and connect it to the posterior fossa dura. But what's important is that the TTL is completely covering the temporal lobe, and therefore there's no temporal contusions. There are no problems with vein of Labbé, and all those problems can be avoided. So once you've developed that plane, you ligate and cut the superior petrosal sinus, and then the dural incisions allow you to connect it to the posterior fossa, earlier open posterior fossa dura. So basically, the posterior fossa dura is open and the PFTL is open. Now that gets you anterior to the stem, and there you can see the the fifth nerve you had visualized there, and that's your tumor there. Now, tumor decompression is like any common tumor removal in this region. In this case, it was suckable, so it was slightly easier. That's a sixth nerve that you see there in the depth. And there, as you go along, we'll see the basilar artery. Here, we also opened the Meckel's cave so that we could work above the fifth nerve, and we could get a very good resection. And there you close it like you close any anterior petrosectomy with a bit of fat. There was a very little small piece of tumor left at the Dorello's canal, which we later on elected to treat with radiosurgery. So that's a long, sorry, I'll just show you that. Yeah, a very small tumor residue that we had to treat later with petrosectomy. Now, as you can see, his function was very good. No oculomotor problems following surgery, even though we had to go all around the sixth nerve in this particular operation. Seventh nerve function, very good. Now, the last part I would like to show is that with variants of this, you can even approach temporal lobe lesions without seeing anything else. So if you have a lesion like this, you have to imagine that this tumor is an archipallial tumor, which is now covered by a neocortex, and therefore you have a lot of tracts there. The ILF, arcuate, IFOF, which are covering the tumor here, and classical approaches involve cutting the neocortex and one of these tracts to reach it. But what if you have an approach like this in which you can do, you not necessarily even do a petrosectomy, just reflect the dura of the middle fossa floor, reach the superior petrosal sinus, open up the tentorium, you can go in and remove this parahippocampal tumor, and while keeping all the tracts intact. Now, this is the approach that we would like to call the epidural subtemporal intertentorial approach. In conclusion, I'd like to say that petrosal approaches shouldn't be dogmatic about the surgical approach, are valuable if properly mastered. But of course, you need cadaver dissection training. We can tailor the approach with these new variants, which are the combined petrosal intertentorial, the apical petrosal intertentorial, and the epidural subtemporal intertentorial approaches. Now, these approaches have a huge potential of reducing the morbidity with petrosectomies, and I hope that this will achieve more popularity in the years to come. I thank you very much, and this is the laboratory that we managed to do all these cadaveric dissections. Thank you very much.
Thank you very much. So, as a chair of the skull-base committee, EANS, it was really excellent talk. Thank you very much. So, Pablo, any comment or question to him?
Roy, that was excellent as usual. And I'm quite biased to ask something because I'm really following and supporting this idea. I think this is the smartest contemporary idea for skull base and also for intrinsic pathology. So I tried it myself when Roy introduced this to me, and I have used it in a couple of parahippocampal gliomas, in which I try always to skip the transtemporal, subtemporal approaches, and it worked really nicely. So the beauty of it is that you don't even expose any single neocortex during this approach. And the challenge I found, Roy, I already told you, was to identify properly the point in which the superior petrosal sinus is attached to the petrous ridge, and for that you already showed me some tricks, but I'd like you to enhance them if feasible.
Okay, so it is much easier if you do a petrosectomy. So let's imagine that a retrolab petrosectomy is done. So the petrous ridge has to be carefully seen, and the middle fossa floor, middle fossa dura reflected, so that you can put some tension on the superior petrosal sinus. And usually the superior petrosal sinus is seen quite well within the two layers, two ridges, that the lateral and the medial ridge of the petrous the petrous ridge. Once you see the superior petrosal sinus, we need to cut parallel to the superior petrosal sinus. Now it may be in one place, it may be a little difficult to get. We may have to move it to another place, anterior or posterior. I find it easiest to open it near the V3. Now, if you don't get it at V3, we go a little more posterior, but somewhere you're going to get it. So it's very similar to cutting the orbitomeningeal band and finding the right place to open the lateral wall of cavernous sinus. So some people open it at the orbitomeningeal band, some people open it at V2. I personally open it at V2, the lateral wall of cavernous sinus. So similarly, the opening of the tentorium can be modified. It can be done anterior or posterior, but wherever at some point we will get it. And once you get it, then it becomes very easy.
Thank you. I found a way using, as I told you, the ultrasound to check it. And even I'm thinking about the use of ICG for that, in case you don't see that. I don't know if that could be a good idea too.
Absolutely. I would completely agree. ICG could help, yeah.
Thank you, Roy.
Thank you very much, Ben.
Yes, thank you. A very nice lecture, Professor Daniel. I have a question to ask about the drilling. I want to ask how during the drilling of the anterior petrosec, and how do you know that you reach the inferior petrosal sinus anteriorly? Yeah, any tips to know?
Well, you will see it. You keep drilling till you reach the inferior petrosal sinus, and of course you will you will know the direction because they both converge at the petrosal confluence. So when the superior petrosal sinus and the inferior petrosal sinus converges, so obviously it's easier to find it nearer that point. But wherever it is, you will see it. So I don't think that is an issue. So it's like a triangle. So it joins at the petrous confluence, and then it gets wider as the base of the triangle is reached. So that should be relatively easy, I think, because it will be visualizable.
I see. Thank you.
Thank you very much, Dr. Roy. Do you have a regular hands-on workshop in your place?
Yeah, so look, our lab is pretty new, Professor Kato, and it's only 3 years old. And the first lab that we are doing is in May, along with Professor Pablo, that is in May 27, 28. But this one is not a cadaver lab, and these are models developed by Pablo's unit, Professor Pablo Gonzalez unit in Alicante. We have 3D models of the head with implanted tumors. So it is a new venture. I hope it will go off well, but these are beautifully designed models with 4 tumors inside the head, all 3D printed. So this is our first conference, and that's going to be done in this May 27, 28. And we've actually diffuse the information all over. I trust people in the ACNS have also got it. If not, I can send it out again. And we are hoping to do it once in 6 months because it's a new kind of course. It's not like the traditional cadaver courses. It's on 3D models with material which is very close to lifelike material. So I'm hoping it will be a success.
Really great. Thank you. Thanks so much. Very fantastic hands-on course. And Kohno Sensei?
Yeah, it's a hands-on course. Yeah, thank you.
Hands-on, thanks.
It was very interesting for me, your talk. And do you do the intraoperative lumbar drainage? Do you do?
Well, the first two cases I did, but after that, now I think the last 7 cases we did not. So I think as you get more and more confident, we are realizing that we can open somewhere the cistern and then you don't really need the lumbar drain. But there's nothing against it. It's a brilliant technique to have dural decompression.
I think so. High positioned region. It's no use. It's no sense. But low positioned region, it may be so useful, I think. But we have to worry about the venous lake, as you mentioned. So we can't know actually before surgery.
True. That is absolutely true. And venous lakes was our problem also, but I've not had a problem with that because we could pack it. But in any situation, if you have a venous lake and you don't think you can split the tentorium, you convert to a classical petrosectomy and then you're still in business.
Thank you. Mute になってます。ミュートになってます。
So thank you very much, Dr. Roy. So maybe we can continue such kind of the collaboration with your society. Thank you so much. ありがとうございました。はい。The next talk would be Dr. Shah. Thank you very much. Waiting for your time, please.
Yes, Professor Kato. First of all, I would like to thank the ACNS and the EANS for inviting me for this meeting. And it's a little bit shift from skull base to the intraaxial surgery, but I think it runs with the theme of the webinar to show anatomy related to surgery. So I'm going to be talking about the SMA syndrome and connectivity of the SMA. So let's look at this tumor. See, this is the central sulcus, this is the precentral gyrus, and here you have a tumor lying in the region of the supplementary motor area. And I resected this tumor completely, radically. We did monitoring for this case, and you see the results of the MEP at the end of the surgery. They were completely intact. But this is how the patient woke up after the surgery. She was not able to speak her name. You can see that she's trying to verbalize, but she's not able to form the words. She's just moving her lips. She's not able to actually form the word.
Durgabai.
Then you ask her to move her legs and hands. She's trying to initiate it, but she's having difficulty. So if you hold the hand, she's able to hold it a little bit, but if you ask her to initiate the task, she's not able to do it. So this was on day 1 of the surgery, and this was on day 6 of the surgery. She started verbalizing. She's standing. She's lifting her right upper limb on voluntarily. Little bit still. Some problem, but significantly recovered, and she's also able to walk. So this is the classical supplementary motor area syndrome. This is another tumor, not in the exact SMA area, but in the pre-SMA area. And here you again see this is a low-grade glioma. We have done an end mass resection, and this was the patient after the surgery. The tumor is on the right side.
Yeah, teacher.
So the he's able to move the hand and on the right side nicely, and on the other side he's having some difficulty in initiating them. But he's able to do it slowly. And
हाँ बताइए, हाथ ऊपर कीजिए,
after 10-15 days of
हाथ
surgery.
के पंजे हिलाइए अच्छे से,
He's absolutely
अभी फास्ट,
fine.
अभी चल के आइए, फिर से जाइए पीछे, फिर
So this is again another tumor with a similar thing, but in this situation, you see that we've gone across the corpus callosum while removing the tumor. I will show the relevance of that later. This is the video of the tumor. So we follow this en masse resection strategy. I will talk about it very soon now. And with a visual impression, we identify the tumor. We use neuronavigation and ultrasound to identify the anterior and posterior margins of the tumor, and then actually go around the tumor, developing a plane of dissection, which is very nicely visible when you get used to this, and you can easily make this plane of dissection. As you can see, you can distinguish the normal from the abnormal, and you see the normal white matter in the depth. This is not a subpile resection, it is an en masse resection strategy going around the tumor, identifying the plane of resection that has been formed by the tumor and removing it. So this is at the end of the resection. You can see that all the vessels are preserved and the tumor has been radically removed. This is the patient at the end of surgery on day 1. Sorry for this. So she was not able to move her right side. Now she has significantly recovered. You can see the difference, but she was not able to move it immediately. And this is about 8 days after surgery. And she started moving, started standing and walking a little bit. And this was again another example who had the SMA syndrome and recovered completely. This was an interesting case of a bilateral parafalcine meningioma I operated few years back. When this patient woke up, she was actually absolutely quadriplegic. She was understanding. She could not speak much, and she was not moving any of the limbs. And the surgery had actually gone uneventful. And I was quite surprised as to what has happened. But then slowly, she started recovering. And this is at the end of 3 months. So this patient actually had a bilateral SMA syndrome. You see the tumor is exactly in the SMA area, but she ultimately did well. So what is this SMA syndrome? It is basically a transitory akinesia of the hemibody contralateral to the damaged site. And if it involves the dominant hemisphere, it may be associated with mutism. So to understand the SMA syndrome, you have to understand this motor network. There is along with the primary motor cortex, which gives the movement command, and the primary sensory cortex, which is responsible for sensory feedback and adaptation. The pre-SMA is actually responsible for planning of movement, and the SMA is responsible for initiation, execution, and coordination of movement. So if this is, you see, this is the central sulcus, the precentral gyrus. So this is the region of the SMA, and this is the region of the pre-SMA. This region is very arbitrarily defined, and this whole medial part is important for the initiation, planning, execution, and coordination of movements. The other component, of course, is the corticospinal tract as it is going down. There are 2 other components that are important in this motor network, as I will show you, and that is this cingulum and another tract that comes on the lateral aspect of the hemisphere. So if you see the superior aspect of the lobe, this is the SMA region. This is actually the region where the superior frontal sulcus meets the precentral gyrus, and this is the motor hand activation area. And this region, you have the frontal eye fields. So on the medial aspect, you have this tract. You see the paracentral lobule here. That is also, so this is just the area in front of the paracentral lobule. The medial part of the superior frontal gyrus is the SMA region. So there is a somatotopic organization in the SMA. The upper limb is anterior and the lower limb is posterior. So that might be responsible for the differences in, the deficits in the upper limb and the lower limb. So as you can see that we have studied the white fiber of the brains in, multiple occasions, and we've developed our own classification system to understand the direction and depth of these tumors and to get a 3-dimensional view. Depending on this, we reclassified gliomas according to our understanding, saying that gliomas arise from a named white matter tract. They remain surgically confined. Of course, pathologically they are diffuse. You will get tumor across, but there is a surgically, you can go around the tumor and actually remove it en masse. And this was our paper on the subject. And you saw this technique that I just showed you. So this is the SMA region. This is the pre-SMA region. So why does the SMA occur? And let's look at the connectivity of the SMA. So if you see this region, this is the SMA region. The first fibers that come in the way are these short arcuate fibers and these U fibers in the depth of the sulcus that connect the superior frontal gyrus area to the middle frontal gyrus areas, and sometimes all the way to the inferior frontal gyrus on the surface of the hemisphere. You can see these connections very nicely, where the superior frontal gyrus joins the precentral gyrus, the middle frontal gyrus joins the precentral gyrus here. Then you can see that there are connections here straight from the superior frontal gyrus to the inferior frontal gyrus, giving an offshoot to the middle frontal gyrus. And there are direct communications between the superior frontal gyrus and the middle frontal gyrus. So these connections are important, as I will tell you later why I think they're important. On the medial aspect, there is this cingulum that goes around above the corpus callosum, and this is the SLF, medial part of the SLF that is present on top of the cingulum. So this part of the cingulum has a role in motor activity, and there is a motor control in this area. The cingulum lies at about 2.8 to 3 centimeter depth from the surface. So that is an important point. Again, I will explain shortly why it is important. And if you see this cingulum, beneath the cingulum, corpus callosum fibers go ahead and join the fibers of the corona radiata. This is the region of the centrum semiovale. You see, this is a very robust connection between the cingulum and the supplementary motor area or the superior frontal gyrus. Now, on the lateral aspect, there is another important area that is concerned with speech. That is the pars triangularis and the pars opercularis. And this whole thing constitutes the classical Broca's area. Also, the ventral premotor area is here. So if you stimulate here, you will get speech arrest. Now, this superior frontal gyrus and this inferior frontal gyrus, as you saw in the previous image, that they're connected superficially by short arcuate fibers, but they're also connected in the depth by this fiber bundle that actually goes from the superior frontal gyrus all the way to the inferior frontal gyrus, and that is the frontal aslant tract. So here you see these fibers coming from the superior frontal gyrus and going all this way in the region of the inferior frontal gyrus. Here you see I've magnified it, and this is the frontal aslant tract. And then another important thing of this frontal aslant tract is it also lies at a depth of 2.8 to 3 centimeter from the surface of the hemisphere. So here you can see these fibers. This is the SLF 2 and 3. This is the arcuate fasciculus. This is the MLF. We don't want to go into this. So basically, the important thing is that this tract, if you want to prevent the SMA syndrome, you need to preserve this tract, the frontal aslant tract, and you do not need to go, you should not, when you're on the medial aspect, you should not go beyond the level of the cingulum if you want to avoid the SMA syndrome. There are some deeper connections to the frontoaslant tract that connect the supplementary motor area to deeper circuits in the basal ganglia. So this is the part of the external capsule, and there are some fibers deeper to the external capsule that connect the putamen all the way to the supplementary motor area. And you see that these are the fibers of the frontostriatal tract that lies medial to the frontoaslant tract. Here you can see these fibers more clearly, and they go all the way. They connect the pre-SMA and all the way back to the SMA. So this is another important connectivity of the SMA region. And lastly, there are callosal fibers that actually go from one side to the other side that connect both the SMA regions to each other. So basically, when you do get the SMA syndrome, there are two things that cause the recovery of this. One is these callosal connections that connect the contralateral side, which takes up the function, and on this side, because of brain plasticity, and the SMA recovers. And the second is the superficial connections on the surface of the hemisphere that I showed you. So some of these fibers may get recruited, and I think they would help in recovery of the SMA syndrome. The other important thing that I would like to add is, we have realized in our, and we have just recently, this paper has been accepted, that if you remain above the level of the cingulum, if you curtail your inferior extent of resection above the cingulum and remain in that plane from lateral to medial, then you will not cross the fat. So, in that respect, you will remain above the frontal echelon tract. And we have seen that we've avoided the SMA syndrome in these patients, in which we have preserved the cingulum also, and we have preserved the frontal echelon tract also. So these are just the callosal connections that connect both the supplementary motor regions to each other. And the cingulum will lie here above this, and the frontal. So both of them lie at a depth of about 2.8 to 3 centimeter. And by remaining above this depth, you can actually prevent the SMA syndrome. So as I said, these are the two things that take over for recovery of the SMA syndrome: these callosal connections as they go from one SMA to the other, and the superficial connections which actually I hypothesize that they take over and cause recovery in the SMA syndrome. Thank you very much.
Thank you so much. Abhidha, always your fantastic fiber dissection, the knowledge is very useful. Thanks so much. So the decisions.
Thank you so much, Dr. Abhidha. That was very interesting presentation and the fiber dissection studies. My question is, what kind of any other tests pre or post-operatively do you use in assessment of frontal echelon tract's function, or this is only like motor function evaluation, or there is some tests that can be used to evaluate the executive functions, which is also, I think, related to the frontal echelon tract area, pre-supplementary motor area.
So if you're doing, of course, if you're doing under anesthesia, all you can control is the motor potentials and the MEP. But if you're doing awake, you can do negative motor mapping, so that when you stimulate these areas and the patient is unable to perform a complex task, like turning a knob or, do bimanual coordination, the patient will not be able to do if you stimulate that area. So that is negative motor mapping. And a lot of people do advocate that for preventing the SMA syndrome. And the argument is actually between curtailing your resection and stopping at that boundary so that you prevent that SMA syndrome, when you do know that the SMA will recover. So it is still a question whether you should, do this negative motor mapping and prevent the SMA syndrome when you know that majority of the time it does recover.
Okay. Thank you so much.
Thank you.
Any comment from Roy?
Well, Abhidha, fantastic talk as always, and I'm always really impressed by the detail, knowledge that you have and the detail you put into your dissections and how that translates onto your intraoperative work. I have only very high regards for your competence and the way you teach anatomy. And thank you very much, Abhidha.
Thank you, Roy.
Okay. Is there any question from EANS? Pablo?
Not too much to say. I was really I know Abhidha very well. We've been together in some places, and I perfectly know this lecture that I have seen a couple of times, and I always enjoy it. And I was very surprised by the challenging result you got with this bilateral parafalcine meningioma. That was scary. That was scary. Whenever you have that, you are always scared and you praying for recovery. But I'm sure you were very, very sure about the proper result.
To tell you the truth, at that time I didn't know. This was, maybe 8-9 years ago. I didn't know. It's only now that I know it was bilateral SMA syndrome. That time I didn't know, but I was happy the patient recovered, at that time.
But thank you, because sharing this information is always fantastic for us to know that we can always hope for a good recovery.
Okay, thank you very much. So, Abhidha, thank you so much. Maybe you're very busy in the another conference. Thanks so much.
Thank you,
Professor. Thanks. So, the pleasure to invite the next speaker, the Luigi, the Maria Cabello. Are you ready to talk?
Hi, Professor Abhidha.
Hi, how
Hello?
are you?
Hi,
Thank
I'm
you.
fine.
Thank you so much.
Sorry if I had to upload my presentation because today, as you can see, I am abroad, but I cannot miss the opportunity to stay with you today and to share our experience on the skull-based reconstruction after endoscopic and Endonasal procedure. Really a big pleasure to be with you. I think Dr. Liu already has my presentation, which I uploaded a few days ago. So please, you can run the presentation and I am here for the question later on.
Okay, so.
Hi, good afternoon. I'm Dr.
Hi.
Liu.
Yeah.
Dr. Liu is operating right now. He gave me the task of playing your video presentation.
Okay.
So I'll be sharing the screen in a moment.
Okay, fantastic, please.
Okay, thank you so much.
Thank you, Luigi.
Hi, Daniel. Good to see you and to everybody. The audio is not running.
Can you see?
Yeah, we can see, but we
Oh,
cannot
okay.
hear the voice.
Oh, cannot hear. Hold on.
Reconstruction. This was considered the sort of Achilles heel of the technique, and the main reason is because the rate of post-operative technique was quite high extended approach, especially compared to the so-called standard approach for extended procedure. We have to recognize early taking post-operative technique because the risk of meningitis or other sensitive damage. These are the coming of extended approach from the signal cellular area in downward the field. There are some specific considerations we have to do on extended approach because in extended approach we have to analyze wider component individual effects that have often an irregular state because there are chronic depression and prominence of neurovascular structure which prevent irregular shape of the opening, and also because we intentionally have to open the paracnal space. There are some risk factors. One of these, of course, is increased BMI. Previous radiotherapy also increased the risk of post-operative leak. Third ventricular opening also is a risk factor for post-operative leak. And also the opening of the basal system, especially the liquid membrane, can increase this risk. And another thing that we have to consider is the intracranial pressure of the over the skull base surface. And in fact, if we look in the literature, there are some cases in which there has been described the prolapse through the skull base defect of the some part of the brain. And this is another case. So, what are the ideal material for the reconstruction? These are, of course, the ideal property. And over the year has been used, and we have used a lot of material in the attempt to reduce the risk of post-operative leak. And today, of course, we can say that the idea, of course, the synthetic, absolutely to be abandoned and not to be used, but also the heterologous one have some limitation, especially in extended approach, and then the best one, of course, are the autologous. Autologous material, which are the best autologous material? What are the best heterologous material? Abdominal fat and nasal flaps. From the medial turbinate, from the nasal septum, and very rarely from the fascia lata. Of course, we have to use some glue, and also in this case, the best one are the biologic glue, and we avoid to use semi-synthetic or synthetic glue. So, what about the reconstruction technique? This is the technique that now we are using. It's so-called the 3F technique, where 3 is made of 3F. It's made simply by fat, flap, and flesh. We parted the 3 of this technique. It's quite easy to be realized. Fat is the first F. So the fat is used to fill the skull base defect. And one important thing is that when you use the fat to fill the surgical cavity, you don't have to use any rigid material to close the skull base, because otherwise you increase the risk to have overpacking with compression on neurovascular structure. And we have used over the year all these variation of the technique, from multi-layer, gastric steel, sphenoid ballooning, global drainage. All of these were unsuccessful. So the way we use the fat is a lack of a cork stopper, not completely inside the skull base, but just across the skull base defect. Exactly like in this picture. Part inside, part outside the skull base defect. So that the fat can fill all the border of the skull base defect. And then we use the flap, nasoceptal flap, to cover the entire skull base surface. So, fat inside, across the skull base defect, and flap to cover the skull base defect. Very easy, very simple to realize. And then we have flesh. That is an early mobilization of the patient with the trunk elevated at least 30 degrees, the early post-op course. So the patient has never to stay supine, because otherwise the pressure of the skull base defect is higher. If you elevate the trunk, the pressure will be reduced. We never use lumbar drainage. This is very important, and the patient has not to stay supine for at least 3 weeks. So in our series, we have used this 3F technique over the last 170 cases of extended approach for a variety of skull base lesion. And this is the rate of post-operative leak, very, very low, similar to the rate of pituitary surgery. Only in 2 cases we have to reoperate this patient because post-operative leak. And just in a few cases we have to inject some additional fabric glue into the sphenoid sinus to control minor. This is some cases. This is tuberculous meningioma. And you see after tumor removal, this is the way we proceed, very fast. Just put the abdominal fat to seal completely the the cavity. No risk of overpacking because you see this transmitted pulsation over the skull base. And then you simply have to cover the skull base defect with the nasoseptal flap. And then you pack with some surgery set. This is the early post-op CT scan. You see the defect which is across the skull base defect. And also you see using suppression fat sequencing after 3 months or 1 year, you see that then gradually the defect will be resolved. This is another case, the larger skull base defect. You see from the supracellular to petrocellular space. You see all the fat, piece of fat are used to pack the space defect, no risk of overpacking, and then with the larger flap, we cover the interstitial base defect and see that after 3 months, this is the signal of fat, and then after 1 year, you see how the fat is resolved.
Move forward a few seconds. Move forward a few seconds. Yes.
You see, on early post-op CT scan, we can distinguish the fat from the air. It is important to know. Also, with some reconstruction, you see over the months how this fat become resorbable. You see this case of craniopharyngioma almost disappear. There are no correlation with patient tissue with the reabsorption weight. We checked, nothing correlate with the patient tissue. So the only thing that we saw is that after 1 year, more than 60% of the fat is resorbed. And last slides, just to show, in case of need of reoperation after some months, how easy it is to remove this reconstruction. You see the flap can be easily detached. You see the neo-dura because the fat favors the regeneration, and you see this was a recurrent radical. Let's see how it was easy to reopen the reconstruction. If you use synthetic material or multi-layer reconstruction, it's not easy as well. This time we opened the button system, the ophthalmologic system on both sides, and then with this better circulation of the TSF, then we reconstruct it with the same nasopeptal flap. This is the last case. You see again after removal of craniopharyngioma, we had some recurrent after some months. It was already resolved, but just to show that when you use this technique, the fat does not create any scar or a lesion. You see, we enter again the intradural that was quite easy to remove these lesion. You see, there are no scars because the fat is produced. So last slide, just to underline the principle of this technique: never use lumbar drainage, never leave the patient square, fill the intradural space with fat, and just cover with the pedicle nasopharyngeal flap, and also mobilize as soon as possible this patient from the belly. This is safe, effective, fast, and with a very low rate of complication. Thank you for your attention.
Thank you so much, Pablo. So thank you so much. So it's very important message from him, I think, especially the 3F his theory, right?
Yeah, I don't know if Luigi is listening, but it's always yes, it's always a pleasure to listen to you, Luigi, on the advances in endoscopic ventral surgery to the skull base. We always learn something new from you, and you've been a guiding force in this specialty. And my practice, at least, I've learned a lot, and I've followed every small step. And most important, what I think you have done recently over the last few years is the emphasis on putting the right amount of fat in the right place. And I think there is no better tissue to repair a skull base defect than fat. And these techniques have meant a lot to ventral endoscopic surgery. And thank you, Luigi, for guiding us in this specialty.
Thank you so much, Dan. Thank you. Really, I'm honored to your work. But this is the summary of the last 25 years in this field. I mean, we have tried everything to reconstruct the skull base. So at the end, the most effective technique was probably the most easy, using just autologous material and with the easy technique. But over the year, we had a really high rate of post-op CSF leak, mainly because we used bad material and multi-layer strategy with that failed a lot of times. So this is just the summary of the experience we accumulated over the year. Thank you so much.
Thanks so much. Kohno Sensei, any comment? Oh, this shot.
Thank you so much, Professor Luigi. That was a great presentation. And so my question is, do you use or do you recommend routinely using the autologous material and no artificial materials like Duragen or any other materials cannot replace the autologous material? And in some cases, we also use fascia lata to reconstruct the defects on the dura. And of course, using the glue is essential. I mean, I want to clarify in this point.
Okay, many thanks for your question. So for standard pituitary surgery, okay, you can use Duragen, you can use other dural substitute. For a minor CSF leak, you can avoid to use abdominal fat. But for extended is something I would avoid, because in case of recurrence is absolutely more difficult to remove these materials. You have more scar, including intradural scar, which are more difficult to manage. So I think a small paraumbilical incision does not increase the invasiveness of the approach. And you have the best material available to reconstruct. And it's something that we use everywhere in the skull base from a long time. And we know how easily it favors the regeneration of the tissue. So I am absolutely in favor to use the fat, even in front of the neurovascular structure. Of course, you have to soak this fat into gentamicin before you put inside. This is absolutely mandatory.
Oh, that's a good point. Thank you so much.
Welcome. Many thanks for the question.
Okay, thanks so much. So any other question? Morisako Sensei? Maybe Please, you can give
Yes.
some comment, please.
Yes. Can you hear me?
Yes, yes, of course.
Yes.
Okay.
Can you give some comment or
Yes, so thank you for your nice concept of the reconstruction of the skull base through the endoscopic endonasal procedure. So my question is there any special procedure to fix the nonseptal flap to the skull base? So usually we use the gel foam material to fix the nonseptal flap for the skull base. So we usually pack the sphenoid sinus by using some of the material. So is there any additional comment from you?
Oh, many thanks. Yes, I have some comment. We don't raise the flap at the beginning of the procedure, but we raise the flap only at the end. We just draw the flap at the beginning, because in this way we can have an increased property of adhesion of the flap. Because if you raise the flap at the beginning, you can have some ischemia of the flap because you have to move to the choana, and also the adhesive property of the flap will be reduced after some hours. If you raise the flap at the end, this property will be much better. And also to maintain, to support the flap, you can use, yes, gel foam, you can use Surgicel with fibrin glue, but to me it's more important to raise the flap at the end of the procedure and not at the beginning. This increases the efficiency of the flap.
Okay, thank you for your comment.
Thank you so
Please,
much.
welcome.
Thank you, Luigi. It was a really excellent educational talk. Thank you so much. So please continue. Yes, thank you so much. Okay. So the last speaker, it's a pleasure to invite Hiroki Morisawa Sensei from Osaka. Please, them yours.
Okay, so thank you for giving me the opportunity to present my current topics. So I'm the Hiroki Morisawa from the Osaka Metropolitan University. So the Professor Hakuba, Professor Ohate, Professor Goto have been continuously modification of the skull base approach to safe and maximum tumor resection. And currently, the endoscopic surgery has been introduced in the management of intracranial lesion, with increasing the indication. So today's my topics is endoscopic subtemporal keyhole anterior transpetrosal approach. So at first, I will explain the detail of the procedure. So the skin incision was like this. So the almost a linear skin incision along the anterior edge of the hairline, and the slightly curved additional posterior side linear incision. And after exposure of the temporal lobe, we made a small temporal craniotomy. And after cutting the dramata of the temporal base, we introduced the endoscope. At first, we exposed the anterior surface of the Petrois bone and the Meckel cave through the subdural approach. And the dramata of the Petrois bone is inserted medial to the GSPN. And the Cowset triangle is exposed. And next, the Petrois bone is drilled out until exposed medial side of the SPS. And the SPS is cut just posterior to the Meckel's cave. And the tentorial incision is made from the cut point of the SPS to behind the dural entrance of the trochlear nerve after opening the Meckel cave. And the cranial nerve, the trochlear nerve, trigeminal nerve, SCA, and the anterolateral surface of the brainstem were well visualized through this approach. So I will show some cases. So this is the trigeminal schwannoma. The tumor located the Meckel cave to the posterior cranial fossa and compress the brainstem like this. We applied this case to the endoscopic procedure. So after cutting the dura mater of the temporal base, we introduce the endoscope and reach to the just above the Meckel cave and open the Meckel cave and expose normal nerve fiber of trigeminal nerve at the Meckel cave and cut the tumor capsule. And at first, the internal developing of the tumor at the Meckel cave and continuous removal of the tumor at first. And so we continuous remove the tumor anterior side. And this is the posterior side. So some part is the obstructed petrous bone. So we drill the petrous anterior petrosectomy and the exposure of the posterior fossa of the dura mater and cut the dura mater and open additional the opening of the Meckel cave along the posterior edge of the tumor, and we expose the tumor more posteriorly and enlarge the surgical corridor to remove the posterior and the medial part of the tumor like this. So after this, the additional procedure, we reach to the medial edge of the tumor like this. So we remove the tumor continuously subcapsular fashion like this. And most part of the tumor could removed through the endoscopic anterior transpetrosal approach. So this is a post-operative MR image. There is no additional neurological deficit. So the next case is this is petrous apex small meningioma. But in this case, the patient showed uncontrolled trigeminal neuralgia after the gamma knife therapy. So we decided to perform the surgical removal in this case. So this is a surgical video. After the small temporal craniotomy, we cut the dura mater and we expose the Meckel cave. This is a lateral part of the V3, and in this case, we simulate the GSPN through the facial nerve stimulation and identify the running course of GSPN and cut the dura mater of the medial side of the GSPN. And we expose the triangle of Kawase. So this is the trigeminal impression. We just expose the bony structure and start to the drilling of the petrous apex. So we expose the SPS and also the additional drilling to expose to expose the dura mater of the posterior fossa. And after that, we coagulate and cut the SPS and expose the tumor itself. So now that we reach the posterior edge of the tumor, so through this procedure, we can detach and devascularization of the tumor itself like this. So we cut the medial edge of the tentorium and identify the trochlear nerve. And the lesion tumor was located anterior side. So we removed the attachment of the tumor anterior edge. And finally, we could achieve the gross total removal of the tumor in this case. So after the tumor removal, the SCA compressed the trigeminal nerve. So we added the transposition of the SCA through the procedure like this. And the transposition of the SCA was achieved. So this is the final view. So through this procedure, we could confirm the abducens nerve, and also we use the angled scope. We could identify 7th and 8th nerve. So after this procedure, we put the fat graft along the drawing part of the petrous bone and finish the operation. So this is a postoperative MR image. The patient, the trigeminal neuralgia improved immediately after the operation. So this is another case. So this is a 60 female. So she had the bilateral CP angled tumor. At first, we removed the right side of the petroclival meningioma. And after the 4 years later, regional tumor has been grown up and compressed brainstem. So we decided to remove this tumor. But the problem is the patient showed some conducting the hearing loss at the right side. So the left side, the hearing loss, we should avoid the additional hearing loss of the left side. So the preoperative CT venography showed this well-developed petrosal vein. So in this case, we applied the endoscopic, the anterior petrosal approach. After the preoperative embolization, we performed the surgery. After the cutting the dura mater, at first we opened the Meckel's cave and reached to the tumor inside the Meckel cave. And at first, we performed internal debulking of the tumor, and also cut the dura mater, the posterior side along the Meckel's cave, and the additional tumor removal of the Meckel's cave was performed. We confirmed the normal trigeminal fiber like this. And after that, we started to the additional drawing of the small amount of the petrous apex and additional tumor removal along the attachment of the tumor posterior side. This is the attachment of the tumor of the tentorium. We gradually enlarge the surgical corridor at the medial side like this. And so the tumor was severely compressed the trigeminal, the caudal and the lateral side. So we make some space to the medial side of the trigeminal and cut the tentorium, the medial edge of the tentorium, and we reach to the posterior edge of the tumor, and we additional tumor removal of the medial side, and this is the attachment of the tumor just above the Meckel's cave. So we remove the attachment tumor along the anterior petrocrural ligament and leads to this is the oculomotor nerve. So we remove the additional attachment tumor, and this is some part of the tumor along the sphenoid ridge. We use the angled scope and remove the anterior side of the tumor along the sphenoid bone. And after removal of this part of the tumor, we could confirm the internal carotid artery like this. And again, the posterior side, just behind the caudal side of the oculomotor nerve. And finally, we open the Parkinson triangle and evacuate the tumor embedded inside the posterior component of the cavernous sinus. And we finish the removal of the tumor in this case. So this is the final view of the tumor removal. So we pack the fat tissue along the petrous bone and finish the operation. So this is the post-operative MR image. We could achieve the subtotal removal of the tumor in this case, and the post-operative hearing was completely preserved in this case. So this is a summary of the the new procedure. The pathology is trigeminal schwannoma, meningioma, and epidermal cyst. Tumor size not so large, but we achieved radical removal of the tumor over the case, and there's no severe complication in this procedure. So this is a comparison of the endoscopic procedure and the traditional, the microscopic, the anterior transpetrosal approach. So the size of the temporal craniotomy and the operation time and the blood loss during the surgery is reduced in this case, and also the post-operative new temporal lobe edema is very small number compared with the microscopic procedure. So the advantage of this endoscopic anterior transpetrosal approach is one of the minimum temporal lobe retraction. So the panoramic view is obtained with endoscopic procedure. So the retraction of the temporal lobe is minimized. So as a result, the incidence of the post-operative temporal lobe edema is lower during the endoscopic procedure, the microscopic procedure. And the second advantage is there is no peeling of the dura mater of the middle cranial fossa. It reducing the risk of the post-operative temporal lobe, the venous circulation. This is one case of the epidermal cyst. In this case, the venous drainage, where the venous drainage is the appearance around the foramen ovale, and so we completely preserve this venous structure after the tumor removal. And third advantage of this procedure is minimal bone removal of the petrous bone. That results in the limited opening of the muscle cell, so the risk of the post-operative conducting hearing loss and CF leakage can be reduced. And finally, the skin incision and craniotomy are small, so the operation time can be shortened. So the indication of the deep procedure is still the small or the medium size of the tumor located at the anterior side of the internal acoustic canals. So this transcranial approach, transcranial endoscopic anterior transpetrosal procedure show the direct access and the short working distance to the petrosectomy region with the minimal petrosectomy. So in conclusion, so our procedure is one of the new skull-based approaches that can be expected to develop in the future. Thank you for your attention.
Thank you very much, Morisawa Sensei. It was a beautiful presentation. So you focus on the pure endoscopic procedure.
Yes.
It was really beautiful. So maybe you can give some advice for EANS, how you can approach to from the microscope to the endoscope.
Yes, so maybe this is a very newly the concept procedure, but recently the minimum invasive approach is sometimes very useful for the limited cases. So during this few years, we started this tumor removal through the endoscopic keyhole, the transcranial approaches. So this is the one of the new techniques. So, but in the future, we can apply the much more the a good indication for the many the skull-based tumors. I think so.
Thank you very much. Maybe Kohno sensei, any comment?
Yes, so I enjoyed your talk. So nice talk. And one question: when you cut the suprapetroral sinus using under the endoscope,
yes.
So don't you ligate the SPS before cutting the SPS? From the video,
yes.
you didn't ligate the SPS.
Usually, in all cases, we ligated the SPS at just the posterior side of the Meckel's cave. We preserve the drainage point of the Petrosal vein to the SPS. So
the small window,
yes.
and so it's very difficult.
Maybe
I
so
thought.
the exposure of the Meckel's cave is very important. So we can estimate the posterior edge of the Meckel's cave. So that is the ligate point of the SPS. Maybe as much as anterior side is better.
Okay. Yes. Thank you.
Okay. Thank you.
So Kohno sensei mentioned about such a small windows. It's quite difficult to ligate. Yes. But Morisawa sensei, you can. Yes.
Maybe so. Of course, the anatomical understanding of the around the petrous apex region is more very important. So the cadaveric dissection or some of the special the training is required to start the newly technique. I think so.
Okay, thanks so
also, the endoscope itself is abstract for ligating the signal.
Yeah. So usually so the scopist, so the assistant is also very important to perform this procedure.
I guess. Yes.
Okay. Thanks
High
so much.
technique. Yes.
Okay. So maybe you can fight each other. Maybe next time. So Dr. Luigi, still, are you with us now? Any comment for Morisawa sensei?
It's nice, really nice presentation. Really nice. But I think that we need more time to say if this technique will succeed or not. But I'm in favor of this technique, of course.
Okay. Thanks so much. Maybe Pablo?
Thank you. Yeah, that was an excellent explanation of the technique. And I wish to know for young neurosurgeons, which is your advice to start with? Because sometimes this, as you were discussing, you are working through a very narrow channel and you really need good surgical skills. So how do you see the learning curve for this kind of approach for young people?
Maybe it's, at first the conventional, the microscopic, the anterior transpetrosal, the very important, and after that so the learning of the endoscopic, also the procedure is so the very important. So usually we perform the endoscopic endonasal approach. So that is very so in our office many the staff can familiar with endoscopic procedure. So maybe both the microscopic and endoscopic, both the study is very important to perform such a newly procedure.
Thank you, Professor.
Yeah.
Maybe you have a regular hands-on course at
Yes. So we have usually once maybe August we will organize some of the cadaveric course there in Japan. Yes.
Thank you very much, Dr. Roy.
I'd like to congratulate Professor Hiroki-san on a brilliant presentation. And these are difficult lesions to operate even with the microscope, and to to do this with predominantly endoscope seems to me fantastic, actually. Obviously, like all Japanese surgeons, you're very skilled at using instruments, micro instruments and the endoscope. And I presume there is many years and many hours of endoscopic work behind as a prerequisite to doing it. Because I looked at your comparison between the parameters of endoscopic surgery and microscopic surgery. Even the operating time has reduced, and that for me is fantastic. I would have imagined that an endoscopic procedure would take a lot more than the microscopic procedure. Clearly, you've done a lot of work and you're very good with the endoscope, and obviously the team that you have created along with your assistant, who's also, I presume, a very experienced surgeon. So you're getting in 3 or 4 hands with the endoscope in. Bravo, I really commend your work, and thank you very much for showing us this.
Thank you very much.
Thank you very much, Dr. Roy. So, any other question? Any shot? Okay, so thank you so much. So now it's at the end of the. Hi, dear shot, please.
Yes, very interesting presentation. Actually, this is a very educational webinar. The topics were selected consecutively, and beginning from the one topic, continuing with the another speaker's topic, which is very consistent and very helpful for young neurosurgeons like us. Thank you so much.
Thanks so much. So, now at the end of the webinar, I think I really appreciate all speakers. So we learned a lot today. So maybe the short summary, maybe the Pablo before Roy.
Roy?
Yes, maybe the short summary. A short summary of the webinar. You have
Pablo, it's you.
Oh, okay. So when I just can say thank you for this initiative. When Roy texted us about this invitation and the initiative from the ACNS, I thought this was like a gift, because joining forces from both sides, it's really fantastic. I really learned much more than what I teach it today. So this is the magic of this webinar. So thank you to everyone for organizing this fantastic initiative. Thank you.
Thanks so much. So the EANS skull-based committee chairman, Dr. Roy, please.
Thank you, Professor Yoko. It's always a pleasure seeing you and Professor Kano and all our Japanese colleagues and the Asian colleagues. It's a brilliant initiative, and I was so happy that when Professor Liu wrote to me about joining forces, the ACNS and the EANS. I've been a member of the ACNS for more than 20 years when I was in India. Among the first members when you called us, Yoko. So it's a great pleasure to join forces, and I hope we can do similar webinars. The largest forces actually are in Asia and Europe, and I would imagine that the courses of this type will be huge, very useful to the large number of residents in both these continents. I hope we can do it at least twice a year, and thank you very much for organizing this.
Okay, thank you very much, Roy. So we are very honored to have you, have your society, and also that some of the Asian YNS will visit your fantastic, the May hands-on, the new approach, the hands-on, definitely. So I think that we'll see in the next time, maybe in a half year or maybe the end of this year. But thank you very much for all. Thank you.
Thank you.
コロ先生、ありがとうございました。
See you. Bye bye.
Bye.
Bye. Thank you.